Good evening, colleagues. Welcome to our live webcast, Basivertebral Nerve Ablation and Intrathecal Drug Delivery. Thank you for joining us tonight. My name is Rene Pescora. I'm practicing at the University of Florida in Gainesville, and I will be serving as the moderator for tonight's webinar. I'm also very proud to be joined by Drs. Timothy Feldheim and Matthew Maroney. Both are faculty in our division at the University of Florida in Gainesville. For the setup for tonight's presentations, which will be two, we're going to present both presentations, and feel free to use the Q&A feature at the bottom of your screen to place your questions. At the end of the second presentation, we will review and answer as many questions as we can go through tonight. Again, please use the Q&A feature to place any questions. We'll be happy to answer at the end of both presentations. I think we'll move along with our first presentation, and this will be given by Dr. Feldheim from UF in Gainesville, and he will be talking about intrathecal drug delivery and pumps, indications, surgical approach, testing, and more complications, and of course, outcomes. Dr. Feldheim, thank you for joining us.
Well, thank you, Dr. Pescora. So very glad to be here talking with everyone tonight. So, our first talk is going to be, as Dr. Pescora said, on intrathecal drug delivery and targeted drug delivery with intrathecal pumps. So very quickly, I have nothing to disclose. In terms of off-label product use, some of the medications that we are going to discuss are not FDA approved. However, everything that that I will be discussing tonight has been, analyzed and by expert and committee consensus, and they have advocated for the use of these medications that will be presented. So diving right in, when we talk about medication management of patients, our common routes of administration of medication are oral, transdermal, intravenous, intrathecal. So obviously, there's some others out there, but these are probably more our primary routes of administration. The first three are probably more common than intrathecal, unless you're doing anesthesia, in which you're doing spinal anesthetics. But the problem with the first three is that most of those medications will go systemic in order to get an efficacy, whereas intrathecal administration can be targeted to the area that you really want to focus on for pain relief. So intrathecal administration medication is nothing new. It's over 120 years old. First described by Augustus Beer and spinal anesthetics, in which he injected cocaine into not only himself, but also one of his lab partners. And if you ever have the opportunity to read the original case report or experimentation reports and journals, it's highly it's actually pretty comical the way they describe how they were plucking hairs out of their legs and groins and saying that they did not have any pain. But some of the things that came about from that was that he kind of discovered was that they was really restricted to the dermatomes in which the medication was administered. Also importantly, that it was reversible and reproducible. And since then, especially in anesthesia, we've been using spinal anesthetics or spinal intrathecal medications very often, and since then, using multiple medication classes for intraoperative and postoperative pain control. As pioneers in this moved on, they started doing spinal anesthetics up in the cervical spine, which now we know is fairly dangerous considering the proximity to the spinal cord and the risk for damage to the spinal cord itself, as well as risk of high spinal and respiratory distress and things of that nature. And over time, we continued to do a lot of research into this. And in the 1970s, we discovered that opioid receptors were in the CNS. And in 1976, Tony Ash, a researcher, found that analgesia could actually be mediated by local spinal infusion of morphine at the level at which the medication was delivered. Despite this, it wasn't until the 1980s that pump therapy was finally utilized for pain management, initially for malignancy and cancer-related pain. However, over the past 4 decades, or 5 decades now, non-malignant pain has become the majority of the reason for use of targeted drug delivery and intrathecal pain pump. And interestingly, but not surprisingly, compared to oral opioid use, IT opioids actually have a better safety record based on morbidity mortality. And as well, because the medication is contained within a pump that is implanted inside of you, there's also much less risk of diversion that has been associated with it. So very brief overview of the anatomy and important anatomical structures. So the intrathecal space, this is the area between the pia and the arachnoid. So if you look at the dissected spinal cord on the right, you can see the arachnoid matter and the pia. The pia is not labeled, but is the layer that is actually adherent to the actual spinal cord itself. And this is where cerebrospinal fluid actually circulates. And over time, we've realized that, bulk flow circulation, meaning, CSF is created in the choroid plexuses, it doesn't actually kind of flow in a cyclical pattern. It actually more pulsates and stays at the level. And depending on which level of the spinal cord you are at, there is either higher or lower flow, but it doesn't flow in a very cyclical pattern. Otherwise, then again, our spinal anesthetics, especially if we were using isobaric medications as opposed to hyperbaric solutions that we use, would just flow throughout an entire CSF. One other thing of note that we'll talk about in a moment is that there are septae throughout the entire spinal cord, and that's designated by the S as well as the green arrows. And basically, those are just sonic kind of tissues that kind of keep the spinal cord in where it needs to be, not like floating around completely. But what's important about those septae is that they really prevent medication, or what will affect us is that medication, so things that we are injected, don't necessarily flow very easily from one side of the spinal cord to the other, meaning that stuff that is injected into the posterior dorsal portion of the intrathecal space does not necessarily flow all the way right around to the anterior ventral portion of the spinal cord. And that's going to be important for us in many ways, and we'll talk about that in a second. And then furthermore, transition of pain through the spinal cord, so things that are going to affect us in terms of our how this will affect our therapy, is that pain or in the spinal cord, the neurons are second order. So they've received input from peripheral nerve fibers out in the periphery, and they then run up the dorsal horn and the dorsal column of the spinal cord. So as you can see, that dorsal horn portion, you have your A delta, your C fibers, and those are primarily in the first and second order, the substantia gelatinosa, which again is 1 to 2 centimeters from the dorsal horn. And they will run all the way up and then terminate in the brainstem, thalamus, and diencephalon, where then your pain is processed in your brain for perception and saying, hey, I hurt. So what's important is that in the dorsal column of the spinal cord, this is where you can actually have modulation. So neuromodulation is an increase or decrease in the pain signal, so we can amplify it or diminish it. And this is done via several mechanisms involving neurons releasing neurotransmitters. So because of that, we can have central sedation and wind up in this area, and that's due to repeated noxious stimuli that can recreate that central sensitization, which is a type of neuronal plasticity, and that can increase the pain signal coding within these neuronal pathways, and that leads to a higher percentage or more intense perception of pain. So intrathecal pump therapy. So what is it? Basically, it's the utilization of a pain pump that is implanted in the subcutaneous fascia of the abdomen. Now, that is with asterisk because FDA is approved for the implantation of the pump within the abdomen. However, if you have a patient who has a cancer or some sort of therapy where they need to access the abdomen, there have been described in the literature that pumps can be placed elsewhere, such as in the back or the buttocks. But it is FDA approved for abdomen placement. And this pump will then infuse medication that is via a catheter that is implanted into the intrathecal space. Um, the wonderful thing about this is if you have appropriate placement, you can actually get a phenomenal pain relief at 1/100th of the dose compared to an oral opioid. And again, this medication is going to be spread into the white matter of the cord, preferably at the or into the dorsal horn, the dorsal side. And because of this, because you're using such a low amount, you have much less systemic effects of the chosen medication or systemic side effects. So who should be considered for this? Patients who have failed conservative therapies, refractory pain, may not be surgical candidates. So looking at the patient selection, certain criteria do exist for patients to be planted or implanted with an intrathecal pain pump. So for the cancer pain population, really they should have at least a 3-month survival or expected survival. They should have failed most conservative therapies. They need to have appropriate spinal anatomy. And this is not just for cancer pain, this is for all pains, but they need to have an appropriate spinal anatomy. So if you're not going to be able to place a intrathecal pain pump due to obstructions in the CSF or due to severe stenosis, where you're not able to thread a catheter into the correct location, they're not going to be a great candidate. And you're probably going to do more harm than good at that point. They also need to have the physical and mental stability to undergo the procedure. So, things that make patients inappropriate candidates, if they have an active infection, they have a coagulopathy, or say they're on an anticoagulation regimen that they cannot come off of for any reason. If they have significant comorbidities that might impair them from being good surgical candidates. And furthermore, if they have mental health issues. So just like our spinal cord stimulator candidates that, need to undergo psychological testing to make sure that they understand the therapy and that they can and that they're an appropriate candidate for it. Same thing for our patients. Now, I will say in the cancer pain population, normally you do not necessarily need that psychological evaluation, especially if you're using it for palliative therapies. So indications, things that, in terms of your patient selection, axial spine pain has probably become one of the number one reasons for placement of an intrathecal pain pump. So these patients aren't really surgical candidates. They may have multiple compression fractures that may or may not be, or that may not be amenable to kyphoplasty, either due to the number of them, or maybe they become chronic compression fractures. Patients with discogenic pain, patients with spinal stenosis. Now, again, with the caveat that the stenosis isn't so severe that you would not be able to place a catheter safely into the intrathecal space. Diffuse multi-level spondyloses that maybe have not responded to more traditional therapies like medial branch block and radiofrequency ablation. Persistent pain post-back surgery, previously known as failed back surgery or post-laminectomy syndrome. Another great patient population where it's been well documented for the use of intrathecal pain pump therapy. Abdominal pelvic pain, whether that be visceral or somatic. So a good example of those would be patients with pancreatitis, chronic pancreatitis, chronic, epigastric pain secondary to that. Maybe they've failed celiac plexus blocks, or they're just requiring several celiac plexus blocks in order to obtain pain relief from that. CRPS, also good candidates for pump therapy. Truncal pains, so patients with post-thoracic neuralgia, post-thoracotomy syndromes. And then obviously, as we've said, cancer pain. Now that could also be due to direct malignancy or invasion that's causing pain, but it also can be for, therapy or chemotherapy induced pain. So real quick, I'm not going to get into the marketing or anything, but I do want to let everybody know that there are two devices on the US market. They work slightly differently than one another. One is a peristaltic rotor mechanism, and the other is a pressure-gated valve mechanism. Here are the two pumps. So Synchromed by Medtronic, that is a rotated or a peristaltic rotator, a rotor mechanism for delivery. They've actually just released the Synchromed 3. I just couldn't find a good picture with the Synchromed 3 with their catheter. So I just used the old Synchromed 2 for the picture, but essentially it looks very, very similar, but the internal mechanisms are slightly different. And then the Prometra 2, which is by Flowonics, and that's that pressure-gated valve mechanism. So important things to note with the pump itself and looking at the pump. So right in the center of each is a little reservoir, a bladder for a reservoir, where you basically place the medication that is going to be infused into the pump. And then on the top of each, you see at the top of that little triangle, there's a smaller little catheter access port that can only be accessed with a smaller needle than what is needed to access the bladder for refill of medication into the bladder or the reservoir. And that is for accessing the catheter. So looking at this diagram of kind of how the very, very simplification of the internal workings of each type of pump, you could see the important thing is that, obviously there's two different mechanisms which are driving the medication into the from the reservoir into the catheter. But the catheter access port is past all of that. So you're only able to access that. And the reasons why you would need to access that are for troubleshooting problems that may occur with the catheter, such as kinking, or if you want to make sure the catheter is still patent, hasn't sheared, where you would do maybe a catheter dye study. The important thing about that is that you cannot access the medication in the pump itself. It is only going to access the medication and the portion distal to that in the catheter, which goes into the spinal cord, intrathecal space. So very quickly, I'm just going to go through the procedure. It's a fairly simple procedure. If you've done spinal cord stimulator implants, it's somewhat similar. The only difference is that obviously patients are laid in the lateral decubitous position, and that is because you will need to tunnel instead of just tunneling to an IPG that you can place anywhere in the back. It is, FDA approved that you place the pump into the lower quadrant of the right or left abdomen. And it's very important to get the patient lined up correctly when you do that, because it'll obviously help you a lot when you make your placement. You want to, just like when you do spinal cord stimulator implants or any other sort of other procedures, you want to make sure that your positioning is best to optimize yourself to be able to place your devices appropriately and gain access to the areas that you need to gain access to. So first incision is made in the midline of the spine down to the fascia for catheter placement via a Tuohy needle. This is fluoroscopic guided. You need an MRI prior to make sure, like I said, that your CSF has no obstructions. Also, you want to enter at an area below the conus so that you limit your ability to, or you limit the risk of damage to the spinal cord itself by inadvertently poking with the Tuohy needle. Once you've gained access into the CSF, you should have flow to confirm entry. And like I said, you want to enter below the conus. Entry, the catheter is then advanced under X-ray guidance to the appropriate level. Important thing about that is that, again, you may want to, or you may bounce anteriorly, but you need to make sure that catheter winds up in the posterior portion of the spinal cord, and we'll talk about that in a second. The needle and the stylet are then removed, and the anchor is placed over the catheter to suture the anchor to the fascia. Again, after you've got your catheter in place, as well as once you've placed your anchor, you always want to be checking for CSF. After every time you check for CSF from the catheter, you want to clamp the end of the catheter, and it needs to be a rubber clamp. You don't want to use something like a Kelly or something that's going to clamp down and destroy the end of the catheter. So you need to just use soft tip catheter or a soft tip clamp. So once you have your catheter in place, then you're going to move on to the implantation of the pump. So you'll make a small transverse incision, the width of the pump, in the right or left lower quadrant of the patient. Again, pocket formation will be then done via dissection to the fascia to make sure that the pump fits appropriately. Once you have your pump pocket formed, you'll tunnel the catheter to the pump locale and attach the pump and access catheter, attach the pump, and then you'll trim any excess catheter that you may have. You want to keep a little bit of excess catheter though. You don't want it very taut because you want to reduce migration. So as you know, you want to place a little bit of the excess catheter behind the pump when you do that. As well, you want to check for CSF, again, making sure that you still have CSF flow after tunneling. And then once you've attached, you can access the catheter access port that I talked about earlier and make sure that you can aspirate CSF still. So as I said, you want to have a little bit of extra loops just for a little bit of stress relief. You're also going to do that at your anchor site before you start to close. Placing those loops behind your pump also protect the catheter during refills because you're going to be accessing that port with a needle, so you don't want to damage the catheter itself. And then finally, you're going to anchor the pump to the fascia. So as you saw on the previous picture of the pumps, they each have about 4 areas that you'll be able to throw some suture. Usually I always use silk because I want something permanent to the fascia, and then you can close. And you always want to make sure that you obviously irrigate with copious amounts of saline because the solution to pollution is dilution. Whether you want to use Vanc powder or not, that is up to you. I personally like to use it. So yeah. So the key thing to make this successful is the importance of location of your catheter placement. So this is going to be important for 2 reasons. One, you want to make sure you're at the level where you're going to be able to target your pain. This is due to how the pharmacokinetics of the medication work, especially in the CSF. So things that impact the medication are the lipid solubility, the baricity. So we're going to be using isobaric medications as opposed to hyperbaric like we do for spinal anesthetics. Regional CSF mixing. So again, depending on which level, you might have a little bit more and a little less mixing. But for the most part, that medication is going to stay at the level. We're going to talk about that in a second. And then whether you're going to use a bolus versus infusion. So as I said, the catheter location is the utmost importance. So posterior location is vital. And what you'll see is that as your medication, we start to, it's been shown by a couple different studies by Bernards in 2006 and then Flack, Anderson and Bernards in 2011, where your catheter is at is actually going to make a huge difference in terms of the distribution of that medication. So as you can see on the right, you can see that at segment 0, so right at the catheter tip, that's where your concentration of medication is going to be the highest. As you move away, you are going to wind up with a logarithmic decrease in medication the further away from the catheter tip you go. So making sure that catheter tip is where you want it to be in that posterior segment is vital. This has also been shown by Wallace and Yash in 2012 with the decrease in concentration of morphine from the catheter in humans as well. This is kind of the landmark study that is kind of proven that we need to be not only posterior, but that we need to be within the certain area of where we want to further targeting of medication in the intrathecal space itself. So as you can see on the left picture, that is an anesthetized pig that had a catheter placed into its intrathecal space. And bupivacaine with methylene blue was then infused at a very low rate, 20 microliters per hour for 8 hours. And what you can see in the second picture then is the distribution of where the methylene blue implanted and as such the bupivacaine. So what you see is that in picture A, that is just the posterior side of a dissected spinal cord from the pig. And you see the methylene blue is really just along that posterior segment or dorsal segment. in picture B, it's been rotated 90 degrees. So you can see looking at it from the lateral side, and you can see that methylene blue is primarily just on the upper portion, which again correlates to the dorsal or posterior portion of that spinal cord. And then in section C, it's been rotated again another 90 degrees, and you don't see any methylene blue. So again, that proves that we really need to have that medication delivered in the posterior side, because that is where the medication is going to have the most efficacy. Now, you can overcome that by using higher and higher doses of medication, but that kind of defeats the purpose of using low-dose targeted intrathecal drug therapy. So if you look on the right, you can see that, comparatively, posterior and anteriorly, at 20 microliters per hour, you're able to get much better concentration of bupivacaine in the dorsal portion or the posterior portion of the spinal cord, which again is where we want to have its effect on our sensory system and not so much our efferent or motor neurons, and very little concentration on the anterior portion. And if we went to a rate of 1 milliliter per hour, you obviously see that it is even higher concentration on the posterior portion, and we are able to get some anterior concentration of medication, but again, nothing comparatively to the concentration that we would get in the posterior portion of the spinal cord. So very quickly, we're going to go through some of the PAC guidelines. So PAC stands for the Polyangies Consensus Committees. So in terms of intrathecal pump therapy, they first met in 2012 and updated their recommendations in 2016 to cover best practices for several aspects of pump therapy. This included trialing, starting doses, patient selection, complications. And since then, there have been 4 other guidelines set forth that are more specific to pump therapy, and that improves guidance for improving safety and mitigating risks, trialing of medications, recommendation to reduce morbidity and mortality, and then consensus, diagnosis, detection, and the treatment of catheter-tipped granulomas, and we'll talk more about that in a moment. So first, the choice of medication that you use. So currently, there are only 3 FDA-approved medications for intrathecal pump use. That's morphine, baclofen, which is used more for spasticity, but can be used for pain, especially if your pain is caused by spasticity, and ziconotide, which is kind of a special medication that we're going to talk about because unless you have some familiarity with intrathecal pain pumps, you probably have never heard of this. That being said, several other medications have been and continue to be utilized, again, for pump therapy. So several different opioid agonists, including hydromorphone, fentanyl, sufentanil. You have local anesthetics like bupivacaine. You have alpha-2 agonists like clonidine. And there are other medications that are out there. These are the ones that are used maybe a little bit more than often and maybe have the best efficacy in the literature for them. So even though there are only 3 FDA-approved medications, 80% of patients with an intrathecal pain pump are currently being treated with a non-FDA approved regimen. So ziconotide, its brand name is Prialt. It's a very small peptide derived from sneeze snail venom. It works primarily as a calcium 2 channel blocker or N-type calcium 2 channel blocker. There's no opioid receptor involvement. It does not potentiate opioid side effects. Strong evidence is for use in diffuse and localized malignant and non-malignant pain. So there have been plenty of case studies that have proven its beneficity or efficacy. And again, both nociceptive and neuropathic. However, titration of this medication is key to its success, and we'll talk about that in a second. So the side effect profile of ziconotide is pretty significant. Nausea, emesis, urinary retention are probably some of the more common ones, and those can happen with any kind of intrathecally administered medication. However, ataxia, somnolence, hallucinations, and speech disorder, those are a little bit more unique to it. And hallucinations can actually be further reversed into, they can actually wind up with psychosis. However, all of these are reversible once the medication is withdrawn. So that is one of the nice things about being able to trial it, to be able to see if this medication should work. So recommendations of evidence assessment of IC therapy. So should be utilized with active cancer-related pain with opioids or ziconotide. Again, there's level 1 evidence with that with strong consensus level. Interestingly enough, IT therapy should be utilized for non-cancer related pain with ziconotide. That has level 1 evidence with a strong consensus level. But for non-cancer pain with only opioid, that's only level 3 evidence with a strong consistent level, consensus level as well. So medication consensus, I'm going to go through this quickly. So non-cancer related pain, this is kind of what we had just discussed. Your best evidence is for ziconotide or morphine. As you see down, move down the lines, they have other options and combination therapies. Non-cancer related pain, again, whether it's with diffuse nociceptive neuropathic pain, again, morphine or ziconotide are your top 2 choices, and then you have other options as you move down the line with evidence for those. Cancer or terminal related conditions with localized nociceptive neuropathic pain, again, ziconotide and morphine, your top 2 choices. Other options as well as you move down. That being said, I just want to bring very close to your attention opioid, bupivacaine, clonidine adjuvants as your line 6. So what are adjuvants? They are medications such as midazolam, ketamine, octreotide. I will say there has been, among many leaders in the industry of the use of these medications. That being said, some of these medications, such as ketamine, can be neurotoxic. Now, if you have a patient who is terminal cancer, it's really more of a palliation at that point. So, it's one of those things where you have to choose the right option for the right patient. If somebody's, using this for non-malignant pain, they're up walking around, they're normal. I wouldn't necessarily go ketamine because again, there's the potential for neurotoxicity. And then again, cancer-related conditions with diffuse or nociceptive pain, again, ziconotide and morphine have the best evidence. So trialing of medications. So non-cancer patients should undergo a psychological screening again prior to implantation. Same for our spinal cord stimulator patients. Expectations should be set prior to the trial. So you really need to have a discussion with your patient. What is a successful trial? Are you looking just for pain relief? Is it going to be pain relief in ADLs? Because I mean, again, this is going to be targeted at a certain area. So if somebody has really bad neck pain and back pain, and you're trying to target their back pain, well, the catheter is not going to be placed in a situation where it's necessarily going to help for their neck pain. So maybe you're, just trying to treat more of the low back pain. And they still have some neck pain. You have to have that discussion with them. Again, is it improvement of activities of daily living? Are they able to walk farther, or because hey, the pain isn't as bad. And those discussions need to be had just like with any therapy we have with our patients. What to do if you have an unsuccessful trial? Plenty of evidence out there. First trials are always successful. Oftentimes it's repeat with a higher dose, or maybe repeat with a different medication. So instead of using morphine, maybe try hydromorphone or fentanyl. Was there an adverse effect from the trial? Did you wind up with severe, if you use morphine, did you wind up with some severe pruritus? Well, maybe then I would switch to a different class of medication, or maybe even, go to ziconotide or fentanyl, something that causes less histamine release. A lot of different opinions on this, but I think I agree with most of the opinion leaders. You really want to use the same medication that you trial with for implant, because that's going to give you, the best idea of how well that medication is going to work. So there's multiple types of trials. You can do single shot intrathecal with or without a catheter. So if you're just doing an intrathecal shot, you can barbitage to hopefully get the medication to spread up and down the spinal cord and give you an idea of how it's going to help. There's single shot epidural injections, again, with or without a catheter, kind of gives you a good idea. Reduces the risk of wet tap, but you might have to use a higher dose of medication. Continuous intrathecal, so with a catheter, so you place a catheter and you hopefully put it at the right level where you want it to be, and just kind of let it infuse for maybe a day, a few hours. And then as well, just like the continuous single shot, or just like the single shot, you can also do that with an epidural catheter, but again, you might have to use higher medication amounts of medication, and again, you might have maybe some systemic results again with that. One important thing about this, there's no superior method that has been established. Personally, I'm a fan of either doing a single shot intrathecal or a catheter intrathecal. But everybody has different reasonings for both. In private practice, if you don't have the ability to monitor a patient or admit a patient overnight for a catheter trial, then single shot intrathecal may be your best bet. Um, but obviously, anytime we do any sort of intervention, whether it be single shot or continuous, we need to have the appropriate resources available to be able to assess the patients and keep them safe. So very quickly, I'm going to go through some of the trialing dosages. So morphine, again, 0.1 to 0.5 milligrams per day, or 0.1 to 0.5 bolus if you're going to be just doing a single shot. I'll let you read through the rest of those. The one thing I do want to kind of bring to your attention is ziconotide. You're using very, very small amounts of ziconotide, 0.5 to 2.4 micrograms per day for an infusion, or a bolus of 1 to 5 micrograms. It is a very potent medication, so you really do not need a lot of it. And using too much on your bolus trial could actually lead to some of those side effects that I had adverse side effects that I had kind of discussed earlier. So recommended starting dosages, very quickly, just want to say they're pretty similar to what they were for the trial dosages. However, your starting dose should be half of the trial dose. You want to do things safely. You want to keep your patients safe. So whatever your starting dose is, should be about half of what you did for your trial. The caveat to that is patients with cancer pain probably or usually do not need a trial. And the starting dose for that is anywhere between probably about a fourth of what they're taking orally. Again, depending on the medication that you use. Sorry, a quarter. So maximum concentrations of daily doses of medications, again, just kind of looking at this. Morphine, again, 15 milligrams per day of a max dose. Your max concentration of your medication should be about 20 milligrams per milliliter max concentration. Hydromorphone, 10, 15. Ziconotide, again, very small doses are needed. 19.2, 100 micrograms max concentration, microgram per milliliter. So dose considerations, you should start with the lowest dose possible for expected analgesia and titrate slowly and safely. This is done based on efficacy and side effects. So if you start having significant side effects, you may need to back down, especially if you're using something like bupivacaine, which can cause some weakness. Pay attention to the side effects based on the medication, especially for medications and combo therapies. And if you're titrating those, you have to realize that if you are increasing one medication, you are increasing both, unless you do a concentration change. If converting from one medication to another, it's recommended to wean from the one medication prior to changing. Patients should be weaned from their oral medications prior to implant, and if able, to before the trial. So their landmark study or a great study by Greider et others in Kentucky in 2011, there was marked improved efficacy if the medication was weaned 6 weeks prior to implant, and then restarted. The patients just did much, much better. And if you have a patient who's on a chronic opioid who's going to undergo a trial, the recommendation is that they hold their short-acting medications probably the night before and then the day of the trial. And if they're on long-acting, hold the long-acting medication the day of. So complications, they're rare, but they do happen. So overdose is the one that everybody's the most afraid of, obviously, but it's actually probably the most uncommon. In comparison, especially if you're going to compare it to patients who have overdoses on oral opioid medications, that's 16,000 oral opioid overdoses a year that cause mortality at minimum. Mortality is usually when started on too high of a starting opioid medication. And that's what you have to be concerned about when you start these medications on these medications. Neurological injury is obviously something that, anytime we're doing any sort of intervention around the spine and spinal cord. CSF leaks, Not so much with the implantation process unless you wind up having to reaccess. But if you have to do a revision, and your catheter has been in for quite a while, and then you have to take your catheter out, the risk of CSF leak is there. Bleeding, obviously, always, and we're concerned about bleeding for any of our interventions, epidural or intrathecal. The development of a hematoma, which would probably require, or that would require a surgical intervention. Infection, again, especially in our patients who are diabetics or have comorbidities that might make them more prone to infection. And this can be at the surgical site or sites when you place the implant, but also during pump refills. So pump refills are things that the patients are going to have to do every 3 months or so. So when they come in for their pump refill, you have to use very good aseptic technique at refilling those pumps. Things specific to the pump refill as well, besides infection. So pocket fills, if you don't access the reservoir correctly, you can inject the medication just in the fascia around the pump. And then obviously wrong medication, or if you've programmed the device wrong, it could lead to potential adverse outcomes. Complications specific to the device, you can have a stall or device damage if you fell on it or something like that. Catheter complications, migration, probably the #1 complication that we have. Just like SCS, migration is an issue. That's why we do all our techniques such as anchoring and stress relief loops to really try and limit that. But you can have kinking. These are catheters that can kink over time, and it's very rare. And then finally, granuloma. So we're going to talk a little bit about medication dose considerations first. So again, opioids, we kind of know what the adverse effects are. It's things that we see often with opioids: constipation, sweating, nausea, urinary retention, especially because you're placing something in the intrathecal space, pruritus, respiratory depression, granuloma withdrawal. We'll talk about granuloma, like I said, in a second. Ziconotide, we've already kind of talked about that. Again, psychosis and suicidal ideation, things that you really need to look out for with this medication. That being said, as soon as you withdraw the medication, it usually or stop the medication from infusing, it usually winds up that the symptoms dissipate. However, there has been times where patients have had to be placed under psychological observation until the medication has completely worn off. Local anesthetic, again, weakness, paresis, edema is possible, bowel or bladder dysfunction, hypotension. We know anybody who's done an anesthesia and has done a spinal anesthetic, those are all things that you've seen. And obviously using doses way higher than what we would be using for intrathecal pump therapy. Baclofen, again, more for the spasticity, but again, sedation, hypotonia, headaches, respiratory depression. Biggest thing with baclofen, major withdrawal symptoms. So if you have a patient on intrathecal baclofen and that has motor stall, but they need to be hospitalized, they need to be, that pump needs to be repaired, or the medication needs to be administered, and they need to be hospitalized until that can take place, and they need to put on high oral medication to avoid some of those withdrawal symptoms, because withdrawal can be fatal, seizures and things of the like. And then clonidine, hypotension, nausea, sedation, bradycardia, hallucinations, respiratory depressions, rebound, hypertension, all possibility. So last thing we're going to touch on is intrathecal granulomas. So what is it? It's an aseptic inflammatory mass that surrounds the tip of the catheter. This is a reaction to the medication. It's not a reaction to the catheter. It's not scar tissue that's surrounding a catheter. It is likely due to mast cell involvement due to histamine release caused by the drug itself. However, there are other factors that likely cause this, things that are still being studied. The first reported intrathecal granuloma was by Rick North in 1991. So things that affect this are drug choice, medication concentration, and dose probably play a factor. So drugs that lead to more histamine release, like morphine, and even to its lesser degree, hydromorphone, those are the medication or the patients where intrathecal granulomas have been documented heavily. There's only a few case reports of fentanyl that in terms of that being a possible cause or offender. The concentration, so lower concentrations, less risk. And again, dose, if you're using low concentration or low dose, you're less likely to have any of those issues. But it still always is possible. If these aren't identified and addressed promptly, it can lead to permanent neurological injury. So if you have a patient with an intrathecal balloon pump, you need to be seeing, you should be seeing them every 3 months for a medication refill at minimum. And at those refills, you need to be assessing for neurological changes. Are they having new weakness, numbness in their legs, new pain, increased pain, especially if you've made some dose adjustments and they're not having pain relief. Hey, maybe there's something that's, brewing in the spine that I need to take a look at. MRI and CT myelogram are the choice imaging modalities in order to diagnose the intrathecal granuloma. So if you look on the right, you can see a big intrathecal granuloma in that spinal cord. So you see the spinal cord kind of terminating, and right below that, you see that granuloma form. Surgical removal may be warranted if the patient is still having significant and progressive neurological impairment. Otherwise, it will go away over time if you remove the offending agent, and you need to basically infuse normal saline at a very high rate until that granuloma kind of dissipates, and then patients usually will have recovery of neurological function if there was a deficit. But it's something you have to be vigilant for in assessing, because the outcomes could be disastrous. So that's my works cited, and that's my talk on intrathecal pain pumps. Very brief overview, but I hope you all learned something.
Dr. Feldheim, Tim, this was an outstanding presentation. I enjoyed it a lot. I know you had to cover a lot, and you were talking for 50 minutes. So I would say, for me, excellent, excellent. And I already see some questions coming in using the Q&A item. I think we'll be happy to answer them at the end of the second presentation. And I see Dr. Mironi also joined us again. And I think we'll follow up with basivertebral nerve ablation, and then we're going to review all the questions we have for tonight's presentation. Matt?
Yep. I
All right.
am sharing.
There we go.
Oh. All right.
Good. Excellent.
Awesome. So yeah, my name is Matthew Maroney. I'm one of the assistant professors at University of Florida, working with Dr. Piscura and a few others, and Dr. Feldheim. So we'll be covering basivertebral nerve ablation. Also, I'll refer to as BVN. I have no disclosures, and this will be on-label therapy. So what is this indicated for? This is indicated for end plate or vertebrogenic pain from L3 to S1, which is a little counterintuitive, maybe, because you can obviously see these modic changes or be concerned about this at other locations. But currently, there's only one tool or provider, specifically a Relievant, that makes the tool Intercept. And that's where it's been studied and indicated for. So not that it can't be done higher or has been done higher, but the tools are only a certain size. And so you'll have to, if considering those things, you'll have to consider safety and, coverage and payment and all those things. I have been told recently that Stryker is creating a competitor that, per them, it may be a different size and may be indicated at different levels, but to be determined specifically. So you can see in this diagram, this is the green is the kind of neurovascular bundle of the basivertebral nerve, which comes from the posterior aspect of the vertebral body, and this kind of spider webs up and down. You can see where directly in the center is where the main nerve is, and therefore that's the main target for your therapy, and that's where you should be targeting under fluoro. So what is vertebrogenic pain, or what do you look for? A lot of people can call it anterior column pain. So that can also be there's going to be some question: is it discogenic or end plate, or in other words, a good candidate for Intracept or competitor, and that's what we'll be talking about in a little bit. But the pattern is going to be axial low back pain, frequently described as aching or burning. You may notice patients will have some days that are worse than others, maybe after activity. The more specific or objective findings you'll look for is worse while sitting. Obviously, you want to make sure this is not in a lazy boy, which I've had a lot of fellows do, where they're they'll say, "Oh, patient feels great," and turns out they're just leaning back, and this which is similar to laying in bed. So I would ask if you're in like a rigid kind of chair with a hard bottom, does that hurt? And a lot of patients are like, oh yeah, in that circumstance it actually hurts a lot. So forward flexion, so if they're putting on their shoes, can hurt a lot. Obviously gardening, you'll hear about washing dishes. That being said, washing dishes is a very common complaint. So I'm not saying that every single one of those patients have vertebrogenic pain. It still could be neurogenic claudication. You should look for what a lot of people refer to as an extension snap, which just means when you transition from a sitting position to a standing position, the patient has a trouble and kind of a painful experiencing straightening up. You'll see patients kind of pushing off their knees a little bit just to straighten themselves up, and which could be worse in the morning. To try to delineate this from neurogenic claudication, I've been taught, though this has not been in the studies, where similar to sitting, statically, not moving, standing can be uncomfortable, and they may feel the need to move. So walking might be a little bit better, which obviously, standing and walking is horrible neurogenic claudication. So it might help you tease that out a little bit. And you can try to percuss the central spine, which the patient may endorse that being kind of the right location or inducing that same type of pain. Though obviously it's not always the case. Just like when someone has a compression fracture, if they have midline pain, that's pretty suggestive, but not every one of them do, because it just depends on the location and of the anatomical problem. So patient selection, more 30,000-foot view, you're going to want someone that has, like anything else, 6 months duration of back pain, that has failed conservative therapy. So imaging findings, which are the learning points for here, is you're going to be looking for modic type 1 or type 2 changes. So the easiest way to remember this is type 2 is bright on both whatever 1 and 2 on MRI, and type 1 is only bright on 2 on MRI. So specifically type 1 is going to be more suggestive of edema, inflammation. I've had people tell me that they think that that's more consistent. I've had plenty of radiologists say that type 1 is more likely than type 2 to be a pain generator, though for the as far as Intracept or these procedures are concerned, either of them is it's kind of binary. If they have either one of those, then you can consider this procedure if you think everything else fits. Type 3 is going to be sclerosis, so that would not be indicated. And I have a picture of that in the future. I think it's important when you're looking at these things to realize that you can have a combination. You could have someone that has type 1, type 2, type 3, and a compression fracture. So, it's, if you kind of scan back and forth, you'll kind of see, like, depending where it is, that like certain areas might be more type 1, some areas might be type 2, and other areas might be type 3. So if you just see type 3 in one location, that doesn't mean that they're not a candidate. It just wouldn't be a candidate for that location if it's completely type 3. So everybody, until recently, everybody's been using MRI for modic changes, and it's been kind of a learning point for radiologists. Until recently, the radiologists wouldn't comment on it frequently because they had no reason to. So they may say end plate changes, but a lot of times they won't say modic. So at our facility, we've had to call, the radiologists, which they generally are very helpful, and say, hey, do you agree that there's type 1 or type 2 modic changes here? If so, can you update your report? Because that will be required to submit to insurance to get or to get paid. You want to make sure, and specifically when you're requesting the MRI, I would specifically put, like, please, evaluate for modic changes, along with, stenosis or whatever you're looking at, fractures. There's going to be some patients that obviously cannot get an MRI. So SPECT scan has been used. I've used it once, and on a patient, and which was positive for end plate changes. CT has been used as well, but it's going to be probably a little bit more bumpy to try to get things approved from an insurance standpoint. But I think it's incredibly important to look at your own imaging, because if you don't look at your own imaging, you can't say that it's there, and you can't make these arguments for radiology. I almost kind of forget to say that anymore, because UF, it's just standard operating procedure. We don't, we pretty much, as a rule, look at the imaging first, and we may look, I'll look at the read just to make sure I don't miss like an aortic aneurysm or cancer or something else I need to follow up on, but I don't rely on it for, MSK stuff. So again, how much is enough? Well, obviously the company is going to say any is enough. You can use our product. You can pay us for the product, which, I don't know. I think there's some probably room for, thought there. If if there's a questionable amount, that patient, I think it's fair to say that, look for everything else. But if someone's, completely lit up and, has multiple areas that are pretty obviously horribly changed, then probably a better candidate. I think it's, from a logic standpoint, makes more sense. But that's what they will tell you. Which, I have to tell you something, so I guess I get it. Let's see, all these things. And one thing I've noted, we work with the neurosurgeons here pretty closely, and I've talked to them about pursuing this on post-surgical, fusion patients, and because I've seen, modic changes directly after surgery. And one of the things they've recommended is at least wait to see, because you kind of would expect some modic changes, if they just fixated an area, and there's going to be a lot of, bone marrow changes. So what's been recommended to me, which I think is reasonable, is maybe wait to see if it stays that way, like get an MRI, over a period of time. And if the modic changes completely fade, maybe it's, not the right target. So what exactly is this? And this is kind of how I look at it, and I think it makes sense. So it's end plate defect, where you can have pro-inflammatory disc tissue that leaks into the bone marrow, inciting inflammation. So, it's kind of the chicken or the egg situation. Does the disc rupture, cause all this inflammation? I think it's pretty clear that annular tears can cause nerve pain because of an inflammatory problem. I think they're, when someone asks, is it discogenic pain or end plate pain, it probably could be both, but we do know that there's a increased density of nerve fibers in the end plates in this situation. So from an anatomical standpoint, the BVN arises from the sinovertebral nerve, which innervates the disc. And that, as you can see with this white arrow, and you can see it frequently in MRIs, and a lot of times I'll show patients that, just because I think it's kind of interesting. All that neurovascular bundle travels in the central vascular foramen in the vertebral body. And so you can see pretty obviously where you'd want to target it. So from an evidence standpoint, really good evidence, I'd have to say. So there's level 1 data, which is the best data you can really have, which is randomized clinical trials. There's level 2 data that has data up to 5 years, and I think there's some that suggest that it's there's pain relief for up to 10 years. Generally, in the level 2 data, 65% decrease in pain on average. Most recently, there was a randomized multi-center clinical trial where, let's see, there was a greater than 50% reduction in pain by a huge percentage of the patients, 72% at 24 months. So this pain relief does stick around, and the argument that because it's not like a normal peripheral nerve, it may not grow back like your standard lumbar ablation. And some of them were home runs. Almost a third, 31%, were pain-free at 2 years follow-ups. And during these trials, there's no serious adverse events, which, obviously I think it's important to say, when you have somebody that's, doing a lot of these, you're going to have probably a better safie profile. Though I will say, I think it's similar to kypho and all these other things. It's not getting a flu shot, but I would say that if you have some, I don't know, if you have some hands, you should do okay, I would say. Let's see, and very recently, a prospective open-label randomized controlled trial with not as lengthy of time they noted 12 months of relief, and it was ongoing past that, but that was just the data they had to publish. So really good data. And this is just briefly shows you multiple trials and pain, starting at around 7, a lot of them drop down to below 4. And, obviously there's some data that goes up to 5 years, but there's multiple studies that go up to 3 to 4. And it's not like it's tapering back up. So that's huge. And patients love that, as they should. So from a technique standpoint, frequently I would say the majority of people do this transpedicular, but I think it is important to point out that there's other options which you'll probably have to consider, especially for this procedure, because you're probably going to have patients that have hardware in the location that you may want to do it. I like doing oblique docking because I think it's more specific. You can really get exactly where you want. You'll, I think from standard AP docking, which is probably the more traditional view, approach, that's how I was taught, which I think is completely reasonable. I think this might be, some people argue it might be a little bit slower, it's more fluoro time, but I think that I save time because I can dock so much more quickly, and I can get like a really ideal angle. I like looking at the facet line when you're trying to decide how much to oblique. I like getting the facet line right in the middle. And if you can see, we're not really at the edge of the pedicle. If you're really completely on this edge of the pedicle, you'll be super lateral, which isn't crazy, but you may not want to do that on purpose. So you're really kind of nearly centered in this oblique view. As you can see to the right, you're going to access the pedicle, you're going to create a channel, you're going to place the probe, and you're going to ablate the nerve. So transpedicular approach, as most, I would assume many of you have seen kypho, but this is similar. So you can see the first 2 pictures, top and bottom, represent what AP and lateral should look like at simultaneous times. So you're kind of at the lateral aspect of the pedicle on AP, you're on the posterior aspect of the pedicle on lateral. And if you're halfway through the pedicle, you should be roughly halfway through the on AP, then you should be also on lateral. And you should not be breaching the medial board of the pedicle until you are about to or have reached the vertebral body on lateral. If you breach the medial board of the pedicle, obviously you risk causing bleeding in the epidural space. If you go too far, obviously you could cause a dural tear, you could cause nerve damage and many other things. I have not noted a report of permanent nerve damage, but there have been reports of other things, which I'll talk about. So final position, you'll kind of see that this is just making the channel, the top pictures, and the bottom is the probe. And so the ablation is proximal. It's not the distal tip of the ablation tool. It's actually at the proximal aspect. So that's why you can see that this doesn't look centered, but the actual where the center of the ablation is actually perfectly centered here. So that's kind of a learning point if you haven't seen it before. I do think that there's S1, which will probably do quite a bit of these things. I think that's where someone could really screw up and hurt somebody or paralyze somebody, specifically because most people don't do sacroplasty, and most people don't, when they're doing injections, they're not identifying the posterior aspect of S1. If you confuse the posterior aspect of S1 and you start medializing too early, you will cause permanent nerve damage and hit S1. So please look at your MRIs. If you haven't done this before, look how your MRI for L5 matches with S1. Get a good fluoro image that you can see at least to some degree the posterior aspect of S1, and be very, very confident of that. And don't rely on your reps to teach you how to do that. It's probably the most important slide of the entire presentation for me. If this will be the reason you do not hurt somebody, and it gets confusing because this anatomy is completely different. So just to reiterate that, I don't know if you can see my mouse, but in this picture, it's pretty obvious the posterior aspect of L5 lines up with the S1 vertebral body. But what I've seen happen with fellows that are obviously new, not their fault, they'll assume that at this first picture on the left, that you're at the posterior aspect of the vertebral body there. And if you make that assumption and you don't catch it and you start medializing because you think you're in the, you will, you could hit everything. You could go completely across and hit the opposite, the contralateral side nerves. I don't want to scare you. I think if you learn this and learn it right now, you shouldn't do it, but it's an easy mistake, even if someone has good intentions. Again, this is a picture of the basivertebral nerve. So, the reason that I want to point this out again is that there's going to be times that you're probably, depending on your personality and how adventurous you are, you may be doing this where there's pedicle screws. You may not be able to go transpedicular. You may not be able to access where you want, and you may have to use the fact that you understand this anatomy to target in a suboptimal location. So you may have to, if there's only one side, one end plate that's really bad, you may have to target that one to get around the pedicle screws. So, just FYI that, that's something to consider. And what are the options? Well, obviously transpedicular is the most common. There's peripedicular, which I've done before, extrapedicular, where I know people have done before. And as you can see, the corresponding, angles of attack here. The reason that you consider the other ones is because, again, there's something in the way. Or you may, I don't know, I mean, there could be other things as well. You could have, fractures of the pedicle that you're worried about or not sure about. So these are, I would say, pretty important. If you're going to consider peripedicular, you want to be thinking about the lumbar artery, which I know this looks like a vein, but the white arrow shows you kind of the position of where the lumbar artery could be. I've had a patient recently that I did do peripedicular approach because her pedicles, I ended up doing it at T12, which is, it's not a normal place to do this. And her pedicles were smaller than the intercept tool. So I did not want to go through her pedicles because I could fracture them, and she was pretty young. So I got an MRA and found out where the lumbar artery was, and actually became buddies with one of the interventional radiologists, and he showed me exactly where it was on the MRI, which was a very different imaging study. And we determined that there was one pedicle that could be accessed if I hit it at a very specific angle at a specific location of the pedicle, and we did it safely. I've talked to other people that are more senior, more advanced than me, and some of them told me, don't really worry about it. So I'm not saying that everyone has to get an MRA, but you should know that the vasculature is there. If you think that there are high bleeding risks, you may want to worry about these things. Yeah. Extrapedicular, so you're going to be worried about the segmental artery, which I think everyone worries about to some degree. So if you're going to access that point, you're going to be on the lower, below the pedicle on fluoro. And as you can see, the white arrow here is kind of where you're going to access, kind of right above the inferior end plate, but not at the level of the inferior aspect of the pedicle, so you don't hit the segmental artery. Obviously, you can see kind of the basic trajectory on the right-hand side. So complications. So what you won't read about, well, you will read about some things and you won't read about others. So you're going to have some post-procedural pain. They'll mention in the studies that you can have some lower extremity pain. It's kind of unclear why that is. I think that most people think it's because if you have lower extremity pain, I think some people thought that as you're ablating, if you're too close from a posterior aspect, could the heat affect the nerves? I think most people don't think that's the case. Though obviously there are details you want to consider. You don't want to be closer than 10 millimeters from the posterior aspect of the vertebral body, and that's why that number is there. So you don't do that. And I think they determined that with cadavers. But if you're not worried about that location, then most people think that you probably breached the medial aspect of the pedicle. I think from an anatomical standpoint, even if you don't completely breach it, you could probably crack it, cause some bleeding. And bleeding is pro-inflammatory, and that can cause some irritation of nerves. I had a patient that had groin pain from her groin down to the medial aspect of her knee. My fellow got really upset about it, wanted to send him to ED, and after talking to him, asking multiple questions, it did not seem like a significant or at all like an epidural hematoma, and I did not feel the need to send her to the ED. I called her the next morning, and she was doing a lot better. But if it's significant, you can't get imaging to see if you breach that pedicle. there have been case reports, or not cases, but discussion that people have had PDPH, post-dural puncture headache. Obviously to do that, you'd have to probably breach, and that breach would have to cause some type of dural injury. And there have been patients that have received epidural blood patches with improvement. So you want to know about these things, because if you do enough of anything, it's probably going to happen to you. So don't be scared of it. It's going to happen. Let's see. Obviously, there's going to be procedural pain, which is axial. So I did a 6-level patient, which obviously I was doing some levels that were not, from L3 to S1. But he had some obviously pretty horrible motor changes. I gave the patient a option. I told him we could split it up in 2, surgical days or 1. He was a pretty ornery dude. That was, I think because I gave him the option, he was like, "Let's do it." He woke up and he was in a lot of pain, but I mean, he shook my hand and he was like, "You told me this was going to happen, and I made it. I made the decision." And he was laughing about it. And I called him the next few days, and it got better, but he was pretty sore. So I would always recommend undersell everything. Tell the patient that you're going to have substantial back pain. It doesn't have to be not horrible. You can consider giving them some pain medication. You're going to probably have you may have lower extremity pain, because I mean, they're probably not, but if they do, they're not going to freak out. And if you don't tell them that, and you don't tell them anything about their pain, they're going to likely be mad at you, because if you don't say something, people assume everything is going to be 100% perfect with no complications. And so we teach our fellows that a lot. Yeah, I think that's it for me. So I know that we kind of ran over a little bit, but do we have any questions? I know there was a few questions for Dr. Feldheim. I'm not sure if there were any further.
Couple for you.
All right.
Yeah, I can actually attest to that 6-level.
Yeah, you can.
Because I was the anesthesiologist for that case.
Yeah, well, it was a great the anesthesia went great, so I appreciate it.
All right, folks, thank you very much for those excellent presentation. I think this is exciting, and I also appreciate that we did review the anatomy, that there's more than bone and discs. Now, a lot of times we're working based on fluoroscopy, and we always think the space is empty or there's nothing vital. So I really, really appreciate it. Also for our understanding when we're going to embark on newer or more advanced procedures, which hopefully the future will give us to our toolbox. I think what we can do is looking at the Q&A, at the questions. I don't know, you want to start from the end? You want to do that? And then that's about for Dr. Baroni, I think most, and then we're having some for the Dr. Felter for the pump presentation.
Okay, sounds good. So where does the sinovertebral nerve come from? So I know that it comes with the central ramus, the ventral ramus. Beyond that, I have not memorized that. So I'm not sure how far it goes back, but good question. We can look about that later. So repeating the BVN ablation. So I'm aware that some people have considered doing this. The question is why, and the question also is, how are you going to get paid for? So, I've seen people, discuss this, and they want to do it because they thought maybe the placement wasn't appropriate. They didn't target that well. So that's going to be kind of the question. If the targeting, so how would you know that? Well, on MRI post-intercept, you'll see the ablation. You'll see a circular ablation, and so you'll be able to tell if you did a good job or not. I would say from a targeting standpoint. So if you saw an ablation that was in the wrong location, you could argue that it needs to be done. And the question is, will the insurance pay for it? And I don't know the answer to that question. I know some people that are trying to do that. Let's see, where was the next one? Okay, to perform BVN at previous surgical levels from fusion. So yeah, so that was So the reason I was going over transpedicular, extrapedicular is because those are the approaches you may consider where someone's done a fusion. So I think as a rule, everybody does them in non-fusion areas. It's going to be a lot more detailed, a lot more technical to try to do that at the level of the fusion. That being said, yes, people do it, and so that's when you probably want to do transpedicular, extrapedicular. Let's see. Hold on. There's a bunch popping up here, so I'm trying to keep up with them. Can
I
you
think
comment
we
more
can do
about?
post-procedure instructions or precautions after the intercept procedure, like lifting.
Okay, yeah. So, well, one of the questions you'll get is, are you going to functionally, structurally endanger the spine? That's actually one of the first questions I asked when I got trained. And the response, which I think makes sense, is that the level, the amount of vertebral body that you're actually like harming is a small percentage of the vertebral body. So there have not been my understanding, there's not been a very high level of fractures directly afterwards, either compression fractures or pedicle fractures. Obviously, if if you try to place that tool, which is I think about 4.5 millimeters through a pedicle, that's 4.5 millimeters, you can fracture it. So you don't generally want to do that, though I have been told by orthopedic surgeons that you can place a pedicle screw the same size as the pedicle and the pedicle will expand. I don't know if you want to, play that game, but you could. Let's see. But post-procedurally, I mean, the biggest concern is just to confirm they don't have, any type of bleed. That would be the big concern. So, I mean, we generally, I try to, as a rule, personally give the patients a call the next day, or that, depending on how they're doing, just to kind of confirm those things. But they don't need, it's not like a SCS where they can't lean forward or something like that. They can do their normal ADLs, and it shouldn't be an issue. Can you comment more about sacral access? So I'm happy to talk about that, but I don't know what you mean specifically. But I think the learning point would be you really need to get good end plate visibility. So you're going to have significant cephalad tilt. Cephalad tilt to me is when I'm leaning towards the head, to match the L5 S1 end plates, or specifically S1, that you're going to be really leaned forward to the point where in some cases, depending on their anatomy, you'll almost be touching them with a C-arm. So that's going to be awkward if you don't really see that. You may be kind of confused by that, but you want to obviously, identify the anatomical landmarks. You should be able, if you do that, you should be able to see the medial border of the pedicle on S1, which a lot of people don't even know exists. But you can't do this procedure if you don't identify that anatomical location or structure. So if you've never seen it before, do it with somebody. So transpedicular, extrapedicular. So transpedicular is standard operating procedure. I would not go extrapedicular unless I had a reason to. Either like the pedicles are too small. There's fixation in the pedicles, like there's pedicle screws, so, I mean, I've only actually done parapedicular, and the only time I'd really probably do extrapedicular is if I was doing a kypho for some reason in a weird location, or there was like some crazy amount of, hardware. Worry about heat transfer to hardware. I'm not aware that that hardware is, the heat's not going to travel up the pedicle screw, and beyond and damage anything. I don't think that's a big concern. But what can happen if there's a lot of bleeding or you're touching something, my understanding is that it won't heat up. Like if you have a lot of bleeding, like if you do it into a hemangioma and it bleeds a lot, then it'll act like a heat sink. And the ablation tool will not heat up. I've done one in a hemangioma, which is pretty funny because all the reps were really worried that, this won't heat up, this won't work, and we did it and it worked fine. And on another level, it bled where there was no hemangioma, so I wouldn't worry about it too much. Patients have typical post-procedure fracture patterns, so patients do have a typical post-procedure fracture pattern, so I do obtain a DEXA scan pre-op and correct osteoporosis without. Yeah, I mean, obviously, I have that conversation. So in regards to having a DEXA and worrying about bone quality, yeah, I mean, I think it's an incredibly important concept that I talk to every patient that has, history of fracture, or I'm concerned about that. Let's see. I want to say that I think a lot of the studies, I don't think they had severe osteoporosis, so you have to take that into consideration. Let's see.
We can give you a break. I think you
Okay.
answered so
Okay.
many, and now we're
All right.
rushing you through it. So that was excellent. And I think I'll turn it back to Dr. Feldheim. Mass, thank you very much.
Absolutely.
Feel free to stay on. And I think, I don't know, we'll go back to the very first questions. And I think they're all addressing intrathecal drug delivery. I think the question regarding a trial prior pump placement you have addressed in the presentation. I know this question came very early on.
Yeah, yeah.
So,
The only thing that I will say, so I use the 2E that's in the kit. If I'm doing a trial, I'm using a spinal needle.
yeah,
If I'm doing or sorry, I'm using a spinal needle. If I'm doing a single shot bolus, if I'm doing a catheter trial, obviously I'm using probably an 18 gauge 2E, and just whatever is in, your typical continuous spinal kit, or whatever kit you use. And then most of the kits that are for permanent implant with their catheters, whether you're using Medtronic or Blowonics, those are 2Es that are in the kit, and those are 16 gauges. Um, Second question, you make back incision after or before the needle dura is punctured. I prefer to make my incision before placing my needle. There have been techniques described where you have dural puncture with your needle and then make the incision around it. Just not how I was trained, not how not my modus operandi, but certainly a reasonable technique, and it has been described out there. This is a great question. It's a kind of trial, daily dose, 0 to 5. When and then when used as an infusion, or sorry, 0.5 to 2.5 when used as infusion, but 1 to 5 mics for a single shot bolus. A lot of that has to do with what the data is out there. Majority, even places where you do catheter trials. So I trained at a place where we did all of our patients got catheter trials except for our ziconotide patients. They were still given a single shot. And that's because there's a lot more evidence for efficacy of that. And there's not as much evidence for catheter trials for ziconotide. What has been described out there, that was the max daily doses that they were getting in a day. It was like 2.5 micrograms per day. So I think that's where those numbers come from. All right. If you take an old catheter out, like more than a few years, would the dural hole heal or stay open and cause persistent CSF leak? So yeah, I kind of touched on that. So that's one of the concerns we have if you have to do like a catheter revision on a catheter that's been in for a few years. Maybe there was a kink or something happened where you have to take that catheter out. So if it's been in there longer, there's going to be more likely to have a CSF leak. Sometimes those are self-limiting, they go away. Sometimes you need to refer to a spine surgeon for a dural patch. During job search previously, there's been multiple practices looking for a provider to take over pumps or to be the one in the practice specializing in pumps. Is it possible for one to minimize call in a private practice setting? If so, what are some of your recommendations? I was in a private practice before I came back to academics, and me and my partner pretty much split call. It's you need to be able to be there for your patients. But at the same time, if you're in a private practice and you don't have a hospital system or you have privileges, oftentimes you're going to be sending the patient, especially if there's something that needs emergent or acute care. You need to be able to send them to somebody who can manage that, whether that be the emergency room and having a good relationship with the hospital if you don't necessarily have privileges there, or having good relationship with a spine surgeon in the area that can help with those kind of issues should they occur, because there are going to be issues. I mean, there are complications, infections do happen, things happen where you need to do more urgent interventions to salvage a therapy or for protection of the patient as well.
perfect.
Normal saline IV or intrathecal for granuloma. Oh, so sorry. I should have been more clear. So yes, it's normal saline in the intrathecal pump that you are infusing at a high rate in order to break up that granuloma. So that will eventually break it up. And usually it's on it's anywhere between like 4 to 6 months. In order to really break up that granuloma and get and then after that, you can potentially still use that catheter. You don't necessarily have to take that catheter out. There have been some case reports where people have changed the infusate, going from sorry, I'm reading ahead on questions, have switched from morphine or combination therapies to, say, just bupivacaine or just fentanyl or things of that nature, low dose or lower medications that have a lower incidence of possibly causing granuloma. Some people replace the catheter, it just kind of depends. And I've had a patient who had an intrathecal granuloma, and they were like, I just want it out. I want the I want the catheter, the granuloma blown away, and then I just want the thing out. And for him, that was the right option. So, it just depends on, what it's got to be, again, discussions with your patients for those kinds of things. For granuloma, does one have to order an MRI with contrast or without? I prefer with. It's just going to give you better visualizations. If I have a patient who I'm suspecting, hey, there might be a metastasis, or they have something, I'm always getting, anything, or even if I think there's an infection in the spine, I'm always getting that with contrast, because it's just going to give you a better visualization. This is a great question. The last question I think that I have. If a patient is on methadone before intrathecal implant, how do you manage the methadone dosage before or after the trial and implant? Any recommendations of the equigenic dose to convert oral methadone to intrathecal opioid? And do I have any recommendations on how to decide the dose of intrathecal opioid if the patient is on oral methadone? Okay. So methadone, as we know, works very, very differently than a lot of our other opioids. It has an extremely long half-life. So if you have a patient who's on methadone, you need to first be assessing, why are they on methadone? Are they on it more for pain control, or are they on it more for maintenance of opioid use disorder, substance use disorder, use disorder? So that should be kind of just dictating where, and also what kind of therapy are they taking it for. So in terms of dosing, the dosing of methadone, in terms of your equigenic morphine milliequivalents, depends on how much methadone they're on. So it's really a case-by-case basis. I have not, fortunately, had to run into this issue very often. But I have seen it. Now, they were on lower dose methadone, and then basically we converted them over to a opioid regimen of oxycodone, and then was able to titrate based on that. But again, you have to be concerned about the half-life and then kind of doing that conversion. I make sure that they are at a good level, and then of oxycodone or some sort of shorter acting opioid regimen, or possibly along with a combination of a long or shorter acting opioid regimen, before I would then go ahead and try and trial. And then obviously, if I was going to implant, I would be making sure that they were weaned off their medication for a good 6 weeks. That Grider study really has kind of proven that, hey, you need to be off your systemic opioids because of the previous sensitization. You really want to have a clean slate to work with.
Right.
So I hope that answered your question well enough. And again, the dose would kind of depend on what more of what I would see in the trial than anything.
No, I agree with you, Tim. That's a very tricky question. And in general, if you think about methadone conversion, getting on or coming off, a lot of the new guidelines or conversion tables, you're going to see that methadone is no longer be presented because it is more complicated. If you find one table or you want to do it and you get more and more experience, again, go low and slow. You may can supplement with any other opiates. And the bottom line is the conversion rate also depends on how much methadone are you on. Let's say, are you under 100 or above? And that's how the ratio will change. And again, many guidelines, I think even on the federal level, have taken methadone away from an easy conversion that tells us something that we have to be careful, or the patients may have to be monitored because we don't know what is needed, what is too much, what is too little. I think we're coming to an end. I really enjoyed the 2 lectures tonight. They were excellent. We had excellent questions, I feel. And I also would like to say that our lecture series is coming to an end. And thank you for staying on. And on behalf of ASRA Pain Medicine and the Association of Pain Program Directors, I would like to thank you for your participation in tonight's event and the excellent questions. And of course, the 2023-2024 Hot Topic Series. I hope I'll see you again for our educational events in the upcoming academic year. Thank you very much and have a pleasant evening.